Okay, we move on the last case. Today's okay. This case is about two siblings from a non-consanguine Vietnamese family. They have normal neuropsychology development. Person no one's at the age of examination was 31. He presented with distal lower limbs weakness and numbness, first noted in adolescence, about 15 years old, with a slowly progressive course. Examination at this time revealed a stepped gash, a mild distal muscle atrophy, a distal weakness with first dorsal reflection was 3 as MRC. He has also distal hypoesthesia in the stocking and glove distribution. That was abolished deep tendon reflex with a vibrator with a diapason at 4 per S at ankle. And there was normal upper limbs. The patient was able to walk without S at last examination. Patient number 2, S examination was 35. She has more severe form with severe distal and proximal involvement of 4 limbs. Muscle strength was 3 at distal and 4 at proximal. In the upper limb, 2 at distal and 3 at proximal at lower limb. She has a pes cavus and Ashwin's contracture. So I would like to show their family trees. As you can see, 2 patients from 1 generation with and there was nobody who experienced this disorder. At least the person no one is the least, and the no two is her sister. Here, I would like to show the detail of the neurologic examination. For the patient, no one, you can see he has the distal weakness, and it's more severe for the patient no two. The first deformity was notable in the patient no two, and there was no involvement of the spine deformity and cataracts neither vocal cord palsy. And there was no pyramidal tract lesion site, and there was no brainstem lesion. Is it nerve conduction study? As you can see, the median nerve that was notable for the multi conduction block in the upper limbs and lower limbs. Here with the block with the conduction block in the both median nerve for the both patient, and the conduction velocity was decreases at intermediate level. There was also the conduction block here as an nerve. There was also a polarization of the latency of the airways, and the conduction velocity was 32 or 35 meters per second. This is the result of the nervous conduction sensory. Now is a nerve conduction study for the motor in the lower limbs. We could not record any potential as a pioneer for the patient 1, but the patient 2 there was slight decreases. The conduction velocity was decreased at the intermediate level, and there was a marker increases F-wave latencies here for the TB and F-waves. Sorry. So here's the picture of the conduction blocks as an ulnar nerve, as about the fibular nerve. Here's the electromyography in the gastrocnemius in the patient number 1 with a chronic neurogenic pattern. And here there was also in the ulnar motor nerve conduction recorded on ADMs for the ulnar nerve. And there was pseudomyostonic discharge from gastrocnemius muscle from patient no 1. So here's our conclusions for the nerve conduction study. There was a reduced MNCV in 4 limbs, multiple conduction block in upper limbs affect median and ulnar nerve in the forearm, our typical nerve compression sites, and the most sensory nerve action potential was aberlis. The needs the electromyography of the gastrocnemius muscle from the patient reveals a high amplitude MUAP and power increasement indicating a chronic neurogenic pattern. And there were also the presence of complex repetitive distress CRDs. Okay, and for CSF analysis performed during the initial diagnostic workup in the patient in the first patient reviews raised the CSF protein level up to 0.007 gram per liter. The patient 1, the first patient has also significantly raises in serum creatinine kinase at 1,600 units per liter, and his brain MRIs show some sign of local arisis bilaterally. Okay, I could stop, and I would like to hear your comment.
Okay, so so I think, as I see, there are a few things that are very atypical about this inherited neuropathy, right? One is this autosomal recessive history. That's one thing that's unusual. And usually, when we see autosomal recessive Charcot-Marie-Tooth or inherited neuropathies, usually they are very severe and present very early. But this patient presented quite late, in late adulthood or adolescence, almost like an autosomal dominant Charcot-Marie-Tooth. The other thing that I'm not sure whether I understood you well, but there doesn't seem to be uniform slowing on the nerve conduction studies. There is conduction block, which is usually, which is usually not seen in classic Charcot-Marie-Tooth inherited neuropathies, right? So that makes me wonder whether we are dealing with inherited neuropathies that are part of a systemic disorder. So that's how I often look at inherited neuropathies. If they come alone on their own, then we often use the term Charcot-Marie-Tooth as a big umbrella term to refer to all these conditions that are isolated from neuropathy. But if they are associated with other system involvement, whether it's mitochondria, cerebellum, spinal cord, white matter changes in the brain, some metabolic disorders, so things like renomyeloleukodystrophies, metachromatic leukodystrophies, spinocerebellar degeneration, all these things the ones that are associated with systemic disorders. So I'm just wondering if this patient has got any other clues. You said that the MRI shows some white matter changes.
Right.
Well, for the MRI for the patient, there was a suggestion of my colleagues from France. At this time, my colleague in France, they note that some patients have similar pattern of EMG and a high level of CK. So they suggest me to perform the MRI for local arisis.
Yeah. So I think that's the other thing. That why is the CK so high? Huh? How much you wouldn't in denervation, you can have a slightly raised CK, but usually not above 1,000. So at this point, maybe I can turn to the audience and see if there's anybody else, has any comments or questions.
Yes.
I can see that there are many. I think many of the Vietnamese doctors are familiar with Dr. Kalpana, who visited you all and conducted a few workshops.
Yeah.
So I wonder whether she would like to comment on this case.
Yeah, Professor Tom, do you want to comment something with the case, Professor Tom?
Thank you, but I have no comment in this case. I'm sorry.
Yeah.
Yeah, hi, Kalpana here.
Hi, Kalpana. Yeah.
Yeah, hi. Can I ask if the patient has any scoliosis?
No, he had not scoliosis.
I see. Okay. Being reflex was done in the nerve conduction.
Excuse me. What is your question? Can you
Just
repeat?
asking, clinically, is there a facial weakness, subtle, mild facial weakness, or any cranial nerve involvement?
No. There was not cranial nerve involvement.
I mean, I would think of autosomal recessive CMT, CMT4, and yeah, and a particular CMT4 SH3 TC2 can present with like similar to an acquired demyelinating neuropathy with temporal dispersion and conduction block. So that's my thought. I think.
Can you repeat that so I can type it out in the chat? So you're saying CMT4.
CMT4, which same thing which you said, autosomal recessive CMT.
Oh. Although this patient's presented quite late, right?
Yeah, but that's why if there has been scoliosis and all that, then definitely it has been going on for some time, and patients don't usually present early because they can still cope. And because I had a patient who actually has presented with 1 year, 2 years history, but she had very bad scoliosis, and it sounded like this is not a 1 year history, but has been going on for many years. And they're able to cope with it, so they don't usually report.
Sure.
And sensory symptoms are also so mild. Only when they get weak in the legs, then they come to you. So I'm just wondering. Actually, when I did the genetic test for her, it is CMT4 SH3 TC2.
So SH3.
SH3 TC2 genetic.
TC2. I'll put it in the chat box for everybody's reference. See whether I've transcribed it correctly.
Yeah, you're right.
TC2. Okay. So this is a subtype of CMT4 that you're suspecting. So this condition, you can have non-uniform slowing with conduction blocks.
Yeah, you can have and also and maybe you can
and
just
also the high level of protein in the CSF.
She also had borderline high protein. So I was thinking whether she had a superimposed acquired neuropathy, and actually I treated her with steroids for a year, 6 months or so, because there was no other family history. She didn't respond because of the bit of high CSF protein. I was also a bit worried whether she had some CIDP on top of something genetic going on, but she didn't respond. So finally I did the genetic test, and it did show this mutation. So I I would think that is one of the condition for your patient. She did have a lot of temporal dispersion, and but conduction block was not so prominent, but she had temporal dispersion. So maybe you can look carefully at the waveforms, whether there is any drop, and besides the drop in amplitude, is there any temporal dispersion?
Can you repeat your question, please?
No, I was saying that maybe, yeah, you can look at the waveform to see that besides the drop in amplitude, is there a temporal dispersion in the?
Of course, there was a temporary,
like one of
temporal dispersion, like this one, you can see.
Bit hard to say, yeah. Yeah, so I would think of that condition. And as Dr. Umar said, to rule out other generalized systemic diseases which can cause demyelinating neuropathy with conduction block and all that. Yeah.
Okay. Thank you for your comment.
Yeah. So generally, I think when we see a genetic what looks like a genetic neuropathy with non-uniform slowing with temporal dispersion and conduction block, then we start thinking about a smaller group of the conditions, right? So I used to think about things like of course, hereditary neuropathy with tendency to pressure palsy can do that, but that's autosomal dominant. Then Charcot-Marie-Tooth X, again, this patient doesn't have that, the inheritance pattern is not a sex-linked. Then I mentioned earlier on about the neuropathies that are associated with other organ involvement like the adrenoleukodystrophies, Refsum's disease,
Refsum,
and Pelizaeus-Merzbacher disease and things of that sort. So these are associated with non-uniform slowing from the, I need to look up my list of peripheral neuropathies that are associated, genetic neuropathies that are associated. So need to look up and see whether they are they have autosomal recessive sort of pattern.
Dr. Umar, I remember very well your lecture when you was in Vietnam for the lecture. You taught us about the extra neurocytes for the hereditary neuropathy. For this patient, there was.
So if there isn't any, like in Refsum, they have sensory neural deafness, they have very severe ichthyosis. So if they don't have any systemic features, then I think in my list, I must add Dr. Kalpana's suggestion, CMT4 for this gene. So I think that's so if it's an isolated Charcot-Marie-Tooth, then I think that diagnosis seems to fit the best.
So for the first patient, we decide for the 4 months of glucocorticoids, and then couple those with no clinical improvement. So we decide to perform a genetic testing with a whole exome sequencing technique for the panel intermediate CMT. And so here is the result of this genetic analysis. So we
please tell us about this.
We found we found double mutation in 2 chromosomes in this gene black5. Is it one in the 2 mutation is caused by loss of the many P nucleotides, leading to the farm sheet work mutation. Okay, so
it's a trinucleotide repeat, is it? Is that what you're saying? Did you say it was a trinucleotide repeat? No, it's a mutation.
Excuse me.
So, sorry. I should let you finish.
Cái đột biến tai nucleotide đó bác sĩ Thủy, đột biến tai nucleotide diclonic mutation.
No, I think I misheard you. Sorry. Please carry on.
Yeah.
I'm sorry.
Okay, so sorry, I don't understand this question.
It's okay. Please carry on. So this gene is associated with
yes. So the gene is associated with the multi block condition block, but there was no literature who describe before. So we found some of the article who describe this mutation cause the some type of motor neuron disease, but not demyelinating polyneuropathy. And the CK level and the high CK level was our question. Is this suggest myopathy coexist with the CMT, or there exists a CIDP in the patient with hereditary polyneuropathy? And I would like to know about your opinion in this question.
Yeah, I think that's an important point, that every time a patient with inherited demyelinating neuropathy, Charcot-Marie-Tooth, who suddenly has a decline in the function very rapidly after a prolonged period of stability and then suddenly decline. The theory is that the abnormal nerves in this particular patients are prone to autoimmune process. So they develop a neuropathy, a secondary demyelinating neuropathy. So normally I suspect that when I see a patient who's been very stable for a long period of time and then suddenly declining. Other than that, I agree with you that if the protein is very high and if there's multiple conduction block, I do give a trial of immunotherapy because we don't want to miss a treatable disease. So I would have done the same thing as what you did. Okay. But I'm not sure whether this patient who seems to have a very chronic process, whether we could call this a secondary CIDP. What do you think, Dr. Kalpana?
Yeah, I mean, a bit tough.
Yeah.
I mean, sorry, she was treated with some immunosuppressant. Is that so? Oh, I missed that part. Sorry. How long was she treated with it?
Steroids, right? You gave corticosteroids?
How long? Yeah, Dr. Tui.
Okay. The first symptom was when the patient was 15 years old, and there was a decline progressively, a long course progressively.
Sorry, Dr. Tui. Dr. Kamana asked you about when you corticosteroid for how long?
Sorry. For the corticosteroids from 4 months treatment.
And no improvement?
No improvements, but we could not try with another immunosuppressant like azathioprine or IGIV.
Yeah, but
we not yet try that one.
Okay, so let me look up a little bit more about this genetic test that you mentioned.
Okay.
Then, maybe we can put up a discussion in our Albatross platform about further discussion about this, and I can consult with some of my. I think Dr. Manji works with Dr. Mary Riley, who's an expert in this area. So perhaps we can ask her to help with this case. Anybody else in the audience who have any other ideas about this? Another very fascinating case that I'm learning a lot from.
I think maybe no more comment, Prabhuma.
Okay. Yeah. Okay. So in summary, basically, for case number 3 and case number 2 and case number 4, we will try to do a follow-up of the case so that we can help these patients through the Albatross platform, and you can continue. Therefore, the audience can continue using the Albatross app. You can continue to see what is the progress for this patient. And so that's what we'll do. And then I've also would put the link for today's recording in the app. so that you could go through some of the issues of this case again, and try to learn more from the various pearls of wisdom that the various members of the audience as well as Dr. Manji has given us today. Okay, so it only leaves me now to thank Dr. Manji. Of course, we have already thanked him. Now I have to thank our host, Dr. Nia, and his team of neurologists from the Vietnamese Association, and also the excellent presentation by the various presenters. Dr. Nia, can you take it from here and end the meeting? Thank you.
Professor Kong, you want to say something?
Oh yes, please do. Please do.
Yeah. Yes, Professor Kong, please say something.
So I have no comment, and thank you very much for Professor Umapati Thiru Grama. I think this type of concern is very useful for us, and as you said, I hope we will organize many times this concern. And thank you for Dr. Nghĩa. You are very actively organized this concern, and thank you for Dr. Lê Văn Thủy. I know Dr. Lê Văn Thủy is in the very active working in the hospital for COVID-19 in Ho Chi Minh City.
Wow.
Despite that, he work in and live in Hanoi. But today he is here with us. Very thanks to him. Thank you, Professor Mapati, so much.
Thank you very much. Thank you. So so look out for the link in a few days' time. I'll put it in the Albatross app for those of you who want to watch the recording again. Thank you. And,
thank you for your time.
Thank you.
Dr.
Thank
Uma.
you.
Thank you.
Thank you, Dr. Uma.
okay. Good night.
Thank you, Dr. Kong.
Thank you, Dr.
Goodbye, Dr. Hiếu.
Goodbye.
Goodbye. Thank